So welcome, everybody. This panel is on psychiatry and medication. And personally, this is an esteemed group here. I'm a little intimidated by all of the intelligence on this panel. So bear with me. So on teams, the psychotherapist often joins clients in psychiatry sessions. And it provides an opportunity for the client, the psychotherapist, and the psychiatrist to become a small team within the larger team. And this relationship, when it starts to really blossom, it allows kind of a protection against splitting. And it also makes available information that might not be able to come to light. So, for example, when a psychiatrist is talking about medication to the client, then if the psychotherapist is present, then they can give that information to the team and help the team understand what they might be seeing. The other direction of that is that the psychotherapist can offer kind of a fuller picture of what's happening on a team to the psychiatrist, and they may not know that. The client may not think of it as relevant, or it just might not come to mind. So it offers this very precious relationship, very intimate relationship. For me, personally, it's one of my favorite things about being an intensive psychotherapist at Windhorse, because I'm able to be part of this fascinating piece of the work. And for me personally, I've worked a lot with Earl. I've also worked with Dr. Winokur and other psychiatrists in Boulder. And I've come to view a good psychiatrist like a good sound man. Sound man. And I say that because with medications, there's the science. So I get to go to a science lesson almost every time, which is just incredible to learn how the brain works and how medicines function. But then also I get to watch this fluid work, changing levels one at a time to see what's happening. And if any of you have ever watched someone with a soundboard, when there's a distortion, if they move all of the levels at the same time, you can't tell what's doing what. And that's the same, at least this has been my observation. It's similar with medications where it's a very fine tuning, and then there's feedback. There's always, it's never in isolation. It's always with more feedback and information. It's a very dynamic situation. And I find that a wonderful aspect of teamwork when there's a psychiatrist present. So I want to introduce the panel. This may not come out in order because I did it in the dark of the night. So, and I don't know whether they sat in the same order or not. So let's see. So first on our panel is Dr. Earl Sugarman, and he's a co-founder of the Boulder Center for TMS and is medical director of neuroagility, a QEEG, and neurofeedback practice. He's worked with Windhorse Community Services teams since 1989 and has a deep appreciation for the powerful healing opportunities Windhorse Care has provided many of his patients over the past 30 years. Earl has worked with people with treatment-resistant mood disorders, traumatic brain injuries, attention disorders, and complex psychiatric comorbidities throughout his career. In serving these challenging populations, he strives to integrate the best practices and emerging capabilities in neuromodulation, functional medicine, and psychopharmacology. Earl has been a psychologist on countless Windhorse teams over the last 30 years and continues this work today. He's an invaluable friend and confidant to Windhorse teams. So I'm going to skip over to Sarah. Sarah Poston is a family nurse practitioner practicing integrative psychiatry in Boulder. She offers a holistic approach to physical and mental health issues. Sarah was mentored for 6 years in integrative psychiatry after completing extensive training in functional medicine. Before becoming a nurse practitioner, Sarah was an RN working in hospice and home care for 13 years. She's gained extensive knowledge of many of the phases and diverse experiences on life's journey from her long professional career, and also as a mother, daughter, and an aging human herself. Sarah sees herself as a partner and facilitator to an individual's unique process toward physical, emotional, and spiritual health. Sarah uses her intuition, her extensive training in functional and energetic medicine, in addition to carefully applied traditional approaches such as prescription management and her treatment. She focuses on sorting through symptom presentation and history to help unravel the root causes, physical, emotional, and spiritual, of illness, to promote health and healing for one's whole being. Sarah is trained in ketamine-assisted psychotherapy and offers this in her primary care psychiatry practice. And Sarah also has been on Windhorse teams as a partner with psychotherapists and clients. Chris Emerson is a bright, silly, and deeply caring counselor, coach, and artist. He specializes in helping people transform their spiritual crises and existential challenges into fun, exciting spiritual journeys aimed at more wakeful, loving, and meaningful lives. A lifelong practitioner of integral practice, Chris provides clients with key insights into their own growth and evolution. Chris has worked closely with leading experts in the field of integral theory and practice over the past decade, including Rob McNamara, Ken Wilber, Dustin DePerna, and Mark Foreman. He received his master's degree in transpersonal counseling psychology from Naropa University and has worked with Windhorse Boulder as a basic attender and housemate for 5 years. Dr. Carl Panzenbeck, did I say that correctly? Pretty good? Okay. Has been affiliated with Windhorse Vienna since its founding, following a teaching there by Ed Podville in 1994. As a clinical psychiatrist, he has worked for many years with people in crisis in the acute psychiatric ward. From the beginning of his clinical career, he engaged in family systems work and has been utilizing the open dialogue approach since first encountering it in Windhorse, Northampton in 2011. He's presently a trainer in that approach. Finally, Dr. Peter Hesse is a neurologist and psychiatrist in practice since 1982. Interested in the scientific work investigating altered states of consciousness, he organized congresses on this topic and has served as president of the European College of Consciousness Studies. As a leading doctor in a psychiatric clinic, Peter encountered Ed Podville's approach to understanding altered states of psychosis. Due to this encounter, he contacted Dr. Podville and began a correspondence with him regarding his views. Dr. Hesse founded the Windhorse Project in Frankenthal in 1999. In addition to his medical work, Peter studied Indian tabla music and music therapy, integrating this with the therapeutic treatment at Windhorse in Frankenthal. So when assembling this panel, it became clear to me that there were some topics of interest that are basically, it boils down to non-traditional approaches, like the use of ketamine-assisted therapy, TMS, neurofeedback, music, open dialogue for treatment-resistant disorders and other complex situations. So these modalities are relevant on many of our teams these days and from its inception. And on our teams, medications are not the only treatment. That's why we have teams. So we also strive to use the lowest effective dose possible, so that there's more available for relationship. So I want to just mention that there are, like I said, there are psychiatrists in this gathering. There's psychiatrists and nurse and basic attender on the panel. So what I'm hoping to do, and this is a lot to corral in a short period of time, is I want each of the panelists to talk for about 5 minutes, 5 to 7 minutes, to talk about what they're interested in and how they integrate into teams. And then I'd like to have, see how the time goes, and then I'd like to have the panel talk to itself. And some of these panelists, it's a first time meeting. So I'd love to be able to, this is sort of like we get a chance to be with a stethoscope on the door, listening to some really amazing conversations. And then I want to open it up for the last 20 minutes to have people come forward, no matter who you are. And if there's questions or experience that you have that you'd like to add to the conversation, then you can come up to this mic here, and we'll just see how it goes. So, Earl, I'm going to start with you, Dr. Sugarman.
Thank you. Thank you, Gretchen. Can people hear me? Yeah. I wanted to, before talking about some of the more novel or less conventional aspects of treatment that Gretchen touched on, I just wanted to talk more generally about my experience of working as a psychiatrist with Windhorse teams. And I consider it a real privilege to do so. I don't, yeah. I was saying that I consider it a real privilege to work as a psychiatrist with Windhorse teams. From my perspective, it's an enriched environment where patients are being afforded often something pretty close to optimal support and good-natured challenge to recover with really adequate resources to do that. And that's such a rare thing these days, maybe ever. In my solo private practice, I'm frequently working with similar patients who don't have the blessing of this kind of support. And frequently, it's a much rockier path. You touched on, Gretchen, the notion of using a minimal effective dose of medications. When I'm working with a Windhorse team, I frequently find that minimum effective dose is lower than I might be able to use with a similar patient without a Windhorse support structure available. And it's a very common experience for us if I'm asked to join a new team, someone coming from perhaps an intensive treatment environment or a hospital situation, that we look over the medications that they come to us with and then start strategizing about which one do we start to reduce first and in what sequence, and oftentimes ending up with something that's a fraction of what we started with. So the medications are often very valuable. That's not to diss the role or utility or importance of medications, but to say that when people are being well supported and their stress envelope is manageable, we don't have to rely on medications to carry as heavy a load as we might in other circumstances. So that's something I've really appreciated, and I don't know if there's psychiatrists, practitioners in the audience who haven't yet worked with a Windhorse team, but I would, if you haven't, I'd really encourage you to do it. It's been a really special and important part of my practice here in Boulder. I've practiced in Boulder for 30 years now and done a variety of different things with my practice that may be relevant to the topics you touched on, Gretchen. With my wife, Carrie Honecker, we operate a neurofeedback practice called Neuroagility. And several of our Windhorse clients have made use of neurofeedback as part of their recovery journey. With a partner, fellow psychiatrist Richard Sudduth, I operate a TMS clinic, transcranial magnetic stimulation, for those of you not familiar with that. That's an FDA-approved treatment for depression that has failed to respond to an adequate trial of medications. And that's something that has played a role in several of the Windhorse teams that I've worked with, not just in treatment-resistant depression, but also a novel use that we may have time to talk about in working with auditory hallucinosis, where we've had 2 patients have substantial reduction in the intrusive voices and intrusive thoughts, and an ability to either go off of medication or substantially reduce medication because they responded so well to that treatment. Ketamine has been a part of my practice for about 6 years now. I got intrigued with it when the first reports of the rapid IV ketamine response in depressed patients first began to come out. And I started looking for a way to make that more available to patients than what was available at the time, which was very little. And what has become more available now are IV infusion clinics, which certainly play an important role, and I refer patients to those. But I've also been able to offer in my office practice to some patients either a ketamine nasal spray or a ketamine sublingual tablet dissolves into the tongue primarily for treating depression that has not adequately responded to more conventional therapies. I haven't used it in a psychotherapy context, as some of the other presenters may talk about today, but more as part of the antidepressant armamentarium that's available, and been very pleased to be able to help some people who hadn't responded to other more conventional antidepressant treatments in that way. Yeah, I think that's what I want to start with.
Yeah, actually my work started in 1977 as psychiatrist in a clinic. For me it was very important to understand what was going on with the patient, especially in the altered state of consciousness, in what kind of situations are they, and how they can be supported, and how these experiences these patients make can be seen as normally. You see, in the general psychiatry, the altered state is something pathological, is something which has to be suppressed, which has to be giving medication, and the heavier the situation is, the more neuroleptics you give. So this was my beginning in the clinic, and I have seen some benefits, of course. People came out of psychosis very quickly with the neuroleptics. They felt less fear and settled somehow again, and could be function quite normal, but they had severe side effects also. And these side effects were so strong that sometimes the personalities changed. They lost their ability for art, for living, for having fun again and in their lives and being content. And so for me it was very helpful also to meet Ed's approach to say that this second state is not pathological. It is, every human being has it. We just have to realize where we are and how we can integrate this altered state. And so with Heike together, I made a training group for 3 years in psychotherapy with psychoactive substances in Switzerland, which was at that time legal, possible to work with MDMA, with LSD, with ketamine a little bit, but not so much, psilocybin, all the different psychedelics, which helped me a lot to understand much better my patients, and also to see the similarities and also the positive sides of the psychosis, because I was always wondering why the people so often stopped the medication. They didn't want to go on with neuroleptics. So I could understand this much better. But of course, psychotherapy is to give as less possible of neuroleptics, and being able to make psychotherapy with them was very important. But I realized also that talking alone did only help for one side, but not fully. And also talking as a doctor with the patient, the doctor is always the experience. He knows what to give and he knows what to do, and the patient is just has to do it, has to take it. And so I tried also to balance this a little bit more and to pay attention much more what comes back from the patient. But by talking alone it was difficult, and I found out using music, making music with these people, or to help them to go into trance with music, and guiding them through in a safe setting helped a lot to understand their psychosis and to help for integration. So for a long time, unfortunately, the psychedelics were illegal all over the world, since there was this one death happening in Switzerland. So we had to stop this possibility. At that time, I just made some experience with MDMA and patients, but as it was illegal, I could not continue. So I was quite happy now to realize that now worldwide the scientific work is going on again to use these substances, especially in cases where all the other medication is not helping. And ketamine was the only substance which has this property, which was possible to use legally. And so, since some years also, I offered some sessions with ketamine, and especially also together with music, and especially with the gong, which is I created a gong therapy in the clinic without any substances, just for psychotherapy approach. And to combine these two, the experience with the gong and the experience with the ketamine, which melted very well together. Maybe we can talk later about these different approaches. But I think there is going on a different paradigm all over the world now, because giving daily medication to shut down the undesired feelings is now changing towards an approach, giving a medication just maybe in a month and then in half a year or whatever, and like the shamans have done it in older times in this intense session for a time which held then for quite a long time.
Hi, can you hear me okay? Can you hear me? It's better, okay. I'm Sarah Poston, and my practice in Boulder focuses on integrative work. Medication management's part of that, but my initial assessment is really broad, just kind of looking at history, trying to search for root causes. They're biochemical things, they're genetic things, nutritional disorders, trauma history, all the work people have done in the past and what's worked and what hasn't. And then very much in sync with Windhorse, I'm always trying to work in teams when possible. I collaborate really closely with therapists and other alternative providers, and like that. So I like your term relational medicine. I feel like that's a huge piece of it. So I was very loosely involved with the phase 2 MDMA trials. I just helped do some physicals, and I was working with Dr. Vanderveer at the time, who was involved with that, and I had clients go through that process. I had several clients from my practice who were accepted into that study, and I saw phenomenal, profound change, and that got my interests going generally with medicine work, and because of the legalness of ketamine. And I think coming out of all the research that's been going on in lots of different ways all over the world, the techniques that were being used with the MDMA trials are being used very similarly with the ketamine-assisted psychotherapy work. And so I work with ketamine in several different ways, like what Earl was talking about, just the properties of the medication. It's very different than any psychiatric drugs we have. It works on the glutamate system. And it's been shown to be really powerful with treatment-resistant depression and stopping suicidal ideation. But, it doesn't necessarily last. And so the model with the IV infusion clinics, they do a series of treatments and then they come back, okay, how long will it hold, and then come back. And so the thinking with doing the assisted therapy, like what's been done with the other medicines, my curiosity was up like, well, maybe we could get more lasting results if we're getting to underlying causes. So that's what got my interest going with doing the therapy with it. And that can be on several different levels. I collaborate with therapists who are using it in their office at very low doses. They do expanded sessions, like 2-hour sessions. And this, of course, is going to be the most cost-effective for people. And so it's like a light trance state, and longer sessions, and it helps get into areas where there's a lot of shame or just blocks where you can't access stuff. And then there's using it sublingual at higher doses where you get into a deeper trance with kind of beginnings of ego dissolving, and there's just a lot of unpacking and insights and visions coming through. And with that experience and with the IM experience, the early part of the journey, when people are more deeper, the support is to go inside and stay with their own experience. And then as they're coming out, then there's more engaging therapeutically. And again, in my view, a really important component with this is in context of primary care psychiatry and in context of everything else they're doing. I think one of the dangers we get into when something becomes the latest, greatest technique is people get like inflated expectations of what it can do. And healing deep trauma is a process, and I think the early developmental stuff can take longer. So for me, a really important part is like, because of my particular background, I require people to have an outside trauma integration therapist, and they'll do sessions with them like a day or two after a session with me. Sometimes we work in dyads with people. Some of that depends on what people can afford. The sessions are 2 to 3 hours with intermuscular sessions or sublingual. And then I also sometimes, when people are in process, I will have people do sessions at home on their own as well. And like I had a client who went through 6 sessions of IM ketamine, and she had this kind of treatment-resistant depression picture, but kind of low grade. And then, so it kind of came flooding back, and then we started doing the home sessions, and she's had really good outcomes with that. And I think it's probably twofold. I think there's a piece that's the psychopharmacology of ketamine as a medication that she's getting a benefit from, and then also, we've kind of joked about it as a date with her self-conscious, at home. So, and that's not appropriate for everyone because some people are going to need more holding in that experience. So, is that a good start?
Well, hey, namaste, everybody. It's great to be here. So I'm on this panel because I straddle two worlds, the clinician side of things and also the client side of things. Due to a series of unfortunate events when I was a young man, like 18, 19, I ended up in a hospital and in a straitjacket and injected with Haldol and taken to a 72-hour hold, the whole shebang. And yeah, got landed with a bipolar 1 diagnosis, and on all these different medications. And so I think what I want to talk about is how I've been able to go from there to now completely off of medication and doing really well. And part of it, so when I had my first episode at 19, there was like a 5-year period of stability on medication, and then I took myself off and had another episode around the age of 24. And then it was actually only like 6 months after that second episode that I started working at Windhorse. And when I told my parents that I was interested in Windhorse, they were like, as a clinician or as a client? And I was like, a clinician? And they were very supportive, and it worked out. And it wasn't something that I told the people at Windhorse about because of all the stigma. I mean, maybe they would have been really, cool and excited that I had just been in the hospital 6 months ago, but I didn't want to risk it. And so it's actually only been now, after like 5 years of working here, that I felt comfortable to come out of the closet with all of this, because I feel like, yeah, they have a sense of me and they know me. And yeah, so the biggest things that have helped me. So I mean, it seems like it's part of the human mind to look for a silver bullet, like wanting just one thing that's going to be the fix for everything. But the reality is that like it's always going to be this myriad of factors that contribute to true transformation and healing. And so yeah, I mean, part of what's helped me is having an integral practice, which basically means that I'm exercising or tending to like all the different levels or dimensions of my being. And so like on the physical level, like I think diet is huge and very underestimated, like the value of. Some people even call it the second brain in the gut, and like, psychiatry in general, like I think should be expanding to include an understanding of the gut-brain connection, because there's so many neurons in the gut that what you eat really affects your mood and whatnot. And so, yeah, I mean, my diet's just evolved so much over the years. I think now the current title is like gluten-free, keto, whole food, plant-based, pescatarian, or something like that. It's very bolder. Like, this diet it's the most anti-inflammatory diet that I've found, and we know that inflammation is responsible for so many different mental illness, even just like emotional issues or physical issues. And so, yeah, and another thing, like I work with Sarah, and she's the first psychiatrist that has ever provided micronutrient therapy. There's a company called Hardy's Nutritionals, which makes a product called Daily Essential Nutrients, and then one called like amino acids, Daily Essential amino acids or something. And basically, these are vitamins that are able to provide mood stabilization and amino acids. And so that was actually instrumental in coming off of the psychiatric medications that I was on. And it's only been 2 months since I've been off all this stuff, and so it is still fairly new. And so we'll see how it goes, but I'm really hopeful. And yeah, and then exercise, of course. Like we know that exercise is at least as effective as antidepressants. And so then there's like, the emotional levels where it's like, does this person have outlets to express themselves emotionally? Do they have a therapist that they like, that they can confide in? Yeah, what are their friendships like? Do they have other people in their life that are supportive? The mental, is a person studying? Are they reading? Are they keeping themselves just stimulated and interested in things? the artistic, creative? Are they, continuing to, express their creativity? And yeah, and then meditation has been huge. And there's, a product called Muse, which is a neurofeedback thing, like a headband, that I've just started experimenting with, but it's a way to, bring neurofeedback into your meditation practice. So yeah, all these things have been really helpful, and there's more that I'm forgetting. I'll leave it there for now.
Yeah, hi. My name is Karl Patzbeck. I'm coming from Austria. I'm a psychiatrist, and the Austrian country is a country where the psychiatry is very much medical style. Even psychotherapy has to be afforded to the main part by the public, by the patients. And if you compare it to the new NICE guidelines, where they say in schizophrenia from the beginning, it's not only the psychopharmacological part to treat, but also the family therapy part. But this hasn't come to our country up to now. I was interested to bring or to get some knowledge about open dialogue, which I heard first in an international Skype with Northampton. People from Northampton mentioned that. And I remembered I wrote a paper 10 years ago before this, and the results were so good that I didn't believe it, and I put the paper to side. But after that, I got interested and was there in Finland and made some connections and even started a training course and a trainer. And the reason was I worked a very long time in the hospital, and my part was in this usual way of doing, having enough free bed on the weekend, and I couldn't set people to the street with medications, so I invited the family and the relatives, so to have more security and to have more a kind of good transition from inside to outside. Knowing this was one of the interests to go into deeper knowledge with family work. And this open dialogue is a product. In the meantime, there are 30 years they worked there in Finland, in West Lapland. And they named it, after a time, open dialogue, before they started to find some principles. And some of the principles are that the dialogue is an important thing, but to be in the way that you can dialogue, you have to listen, to carefully listen. And then there is a reflective part in this kind of socializing kind of therapy. Reflective part where there's more than one therapist. Talk to each other, maybe you know this from the reflecting team, and the clients, the family, the network, take up whatever they choose, whatever they find good, and then it goes back what the clients, what the network could resonate with. So these are sessions about 1.5 hours, 2 hours maybe. And my interest was maybe why not use it in the winter setting? And there's one idea behind the open dialogue, that psychosis is not an individualized a problem of an individual. So it is an energy area who has a lot of influences from different parts. Some parts are not known to the other people in this network. And many of these traumatic experiences didn't have words up to now. So the start is to invite or create a network with relatives, family, sister, could be friends, could be work colleagues, whatever. We experienced with that a lot. And this creating of a network released the client, which came to us, and very often coming alone to a psychiatrist wasn't possible because there was a lot of anxiousness and a lot of strangeness to go to a doctor. So using this setting, this is the base, and in Finland it's called the therapy meetings. And there are therapy meetings over the time. And they start with the acute crisis and are held in these therapy meetings in the flat of the client, or in a city center, or in an outdoor clinic, but not in the hospital as it is done usually in Austria. So it is very mobile, and the therapists go out to this, and this is continued till it is not necessary so much. And in the 5-year outcome, they had 34 of these network meetings to fix, to go with this first episode, a psychotic experience. So in this area, medication plays an important role about lesser medication or non-medication. If you are alone in a private practice, you have only one-to-one client, and how do you know how it works? And to whom do you correspond? So the situation was there, inviting the family. That's family therapy in a way from the psychiatric standpoint. But in the Windhorse setting, you have the basic attenders who have an impression about how this new medication or the change in the medication, what kind of effect comes out. And in these therapy meetings, the family, the client have their space of expressing themselves, and also the basic attenders. So, and this is the start from the dialogue, ending in a reflection and re-reflection. So that's about the model we use in some of the family sessions. Because just one step back. In the beginning, there was the family session had the character of creating a good atmosphere with cakes and coffee and knowing each other. Yeah. And the question was, why not using this in a therapeutic way, dialoguing, reflecting, and so this was one of the reasons why I was eager to do this. So maybe I'll stop there.
Fabulous. I have you where I want you. This is fantastic. Thank you so much for sharing that. And I'd like to see if there are any topics or anything that pops up among you to talk to each other about. So, Earl, you're sitting here. Anything you want to riff on there?
Well, one of my curiosities, partly coming from having worked for a while with ketamine, partly trying to understand more about how it works, is a notion of regenerative medicine meeting psychiatry, or regenerative psychiatry. I think stress reduction is a form of regenerative medicine, because we know that the effects of prolonged and intense stress are actually toxic to brain structure, synapses, neuroneogenesis, and reducing stress promotes recovery in that way. But I'm curious if others in the panel or others in the audience have thoughts about this realm. It seems to me like we're just beginning to scratch the surface of something that I think is going to be very important moving forward.
Curious on the panel, regenerative, any thoughts on that?
For stress reduction, actually, my point of view is instead of giving normal medications like tranquilizers or something like this, CBD actually is, in my point of view, the ideal substance you give daily in a certain amount, which is good for the patient, to be able to have this inner balance. That what I have heard a lot now. I'm giving CBD in my practice and try to reduce neuroleptics and giving more CBD. In high doses, CBD can also act as neuroleptic. It has the same result if you give 600 milligram CBD and more, then you can even shut down the psychosis acute. But in low doses, you have a really the endocannabinoid system is balanced, and this helps a lot to reduce stress.
What sort of doses?
Depending on the patient, but from 25 to 200 or 150. So in this range, it is ideal. If you give more, then it can also act as antidepressant medication, and if you give even more, it's antipsychotic.
I'm really appreciating what both of you guys said, because the piece with stress is so huge with that. And I think, and I also use CBD in my practice. I haven't experimented with high doses, but I was very interested to hear you say 600 milligrams, because I haven't heard people talk about going over like 100 or 200. So I'd like to hear more about that, actually. But, and like Earl said, we're just scratching the surface with ketamine, and that's kind of how I feel. Like, I wouldn't make a statement about it, but I have curiosity, because I feel like if you could, my experience with that kind of unpacking of the patterns and those shifting in life, like, it can be huge, and that's addressing it, using it more, connecting with the divine or having a more transcendent experience actually can make huge changes for people in terms of stress and how they're relating to the day-to-day of their life, because they feel more connection to life, and some of the existential stuff that's really feeding depression and anxiety, calms down for a lot of people, and that can be helpful too. So, do you have anything? Yeah, I'd love to hear more about CBD dosing.
Well, in a university close to our place, they have done this scientific work using CBD in very high doses and proving that it's similar effective than the normal neuroleptics, but they are using 600 to 1,000 milligram daily, which is really expensive. It's really expensive, and this is the only which also is holding myself back to tell this to people, to prescribe it, because it's so expensive till now. It should be much less expensive, of course, if hemp would be legal everywhere and much more grown, then it could be much cheaper, much cheaper. But it is, you can also combine it with small doses, or reduce your, or even give up the tranquilizers, or it also helps for addiction to use alcohol as a calming down So. Maybe for yourself, because you also have experience with MDMA in psychotherapy, we were discussing a lot if really ketamine could be used also in the same way as the only difficulty to use ketamine as psychotherapy or in psychotherapy is that the patient or the participant actually can easily forget the contents, what he has from insides. This is like a dream. If you don't pay attention, it's just phew. So you have to record the session. You have to really always repeating the content. And I'm convinced that it's really necessary to talk and for integration to see what's coming up from theme, not only just giving the substance which does an effect, which helps you to, like in a computer, you push the button and the depressive thoughts, they are gone. But instead, using the material which comes up to really handle it and to really integrate it.
I have a somewhat humorous anecdote along those lines. So most of the way I've offered ketamine in my practice has been as an antidepressant therapy for chronic treatment-resistant depression. And so I'm prescribing for people who are then self-administering at home. One of my patients had been using ketamine for several months and with fairly minimal benefits. Hard to say that he was getting any good experience out of it at all. But he came in one day and he said, "It's working now. I'm much better." And I asked him, "Well, what changed?" This is kind of embarrassing for me. He said, "Well, you had told me that I should, when I use the ketamine, it should be when I'm done with my day and when I'm through with my responsibilities and I have a quiet place. And so I was in the habit of taking my ketamine and turning on the news." Seriously. And for the first 2 months, that's how he used it. And it didn't help at all. Fortunately, he self-corrected, realized that this was not a good idea, and then began to create a much more relaxed environment without any TV and with calm and soothing music. And the change was remarkable with just that difference in the environment.
I wonder how I come to my part, because the question is how much can the presence of a person be effective just by touching it or by spending some time with it, or even better, going into a communications situation and talk to each other. The question is, isn't that tranquilizing, stress releasing by itself?
I'm going to riff on CBD a little bit because that's been super helpful as well for me. I'm actually under the influence right now. It's really should be something that is like you're able to get insurance to pay for and pick up at a pharmacy, and hopefully we'll get there. It's, as psychiatry starts exploring more of these psychedelic therapies, CBD could also come in really handy for, because it's an antipsychotic, but it's also an anti-psychedelic. And so if someone's having a bad trip on, cannabis or psilocybin or something at these very high doses of CBD, it could, reduce the psychedelic effects and reduce the horribleness of the trip. And I'll stop there.
Just one more, maybe CBD for the whole family, because if one takes it, what is with the communication which is going on with the family members? And if you are getting tranquilized and somehow released, then still the evaluation goes on and high expressed emotion, for instance, or this old concept of Frieda von Reichmann with a schizophrenic parents, I say, not mother, but parents, or society. What about that? So there's a danger to personalize this this situation, which is diagnosed as a disorder of one person, but that's not real.
Yeah, that's totally my experience, that it's a system, you got to treat the system. And, you know, like with teenagers, when I work with teenagers, it's so limited, actually, what you can do with them effectively if the whole family isn't involved. And I'll do a whole team thing with teenagers with parent coaching and, you know, the parents doing their work, then everybody coming together. And I think it's a better model. It's hard to get people to buy in, parents, sometimes. But about what you were saying with the, if ketamine can have that same thing with MDMA, you know, I think we'll figure it out more as we go. You know, the thing with the disassociation aspect, so ketamine's not a classic psychedelic, it's a disassociative, and at higher doses you have full ego dissolution and no sense of your body. But at the lower doses, I think, I just have curiosity, like I almost wonder if there's more power, you know? And I have a big bias with doing a lot of integration work. And then when I sit with people in deeper sessions, like I take notes about what they're talking about and I share it with their therapist and I give them a copy. And then as they're coming out, we talk about the content. And then that's part of the reason to do integration so quickly. There's something else you said. Oh, I think another kind of nice thing about ketamine is it's really gentle, and you also don't, like with MDMA, you have to be off all your medications, and that's just not accessible to everyone. I mean, I'm curious over time when it gets legalized and the edges are pushed a little more, if that's going to be as true. But, you know, like in the study format with MAPS and all that, people are 100% off meds, and that makes it way less accessible to a lot of people. So that's one of the things that I like about ketamine, is that it's more compatible with people who are on 1 or even 5 psych meds. So.
Yeah, I also think, like you, that the system is very important, and so often we are inviting for a session that the partner comes with it. Also, in a way, it's like the old shamans were working. They were not working in a one-to-one situation. The whole family, the whole village is present, and to realize it's not only this person who is ill.
So I'm watching the clock, and I'd really like to open this up to everyone. So if you have a comment or a question or just a way to add to this, there's a microphone just over here. I know it may be the long walk, but please, oh, awesome. Dr. Winokur.
So I'm Bill Winokur. I'm a psychiatrist in private practice here, and I first started working with Windhorse Teams probably back in 1994. So I don't know if I have as much experience as you folks in terms of working with teams. But I actually have a challenging question, and you'll have to tell me whether this is a little bit sort of off topic or not. But my experience in working with Windhorse Teams has been that, one, I like the team approach, but there's also been a very, very calming aspect to the sort of Windhorse model and the Windhorse approach. So what I would like to hear from, from the panel is a kind of a discussion about, from a psychiatrist's perspective, what's special about working with Windhorse? how is that different than just working with some other support program? Because I've worked with other intensive models, I've worked with residential programs. And so what have you found is special about working with Windhorse teams?
Thank you. That's perfect.
Bill, I'm not sure that I have a lot to contrast with. I think I've had most of my team treatment experience has been in a Windhorse context. I mean, I partner with psychotherapists and we'll have occasional dialogue with them as treatment evolves in individual care, but not nearly as organized or as regularly or as, I guess, mindfully as the usual schedule in which I'm included in a Windhorse team process, which is on most of the teams fairly regularly and pretty intentionally. That said, I guess one of the characteristics that I think characterizes the Windhorse experience for me is the long view that is often available to be taken in the recovery process. I say often because it's not always. Sometimes we only have 3 months of funding to work with a situation. And that's very different than a more open-ended possibility where the team begins in an intense fashion with lots of staffing and lots of contacts with me. And as if things go well and progress is being made, that begins to wind down as other community activities begin to take the place of basic attendance and less frequent medication interventions are needed. So I guess it's been unique for me in that way. If I compare it to, say, inpatient acute, which is also a team process and one that I've done a lot of and valued, it's a 3 to 10 day gig, and then it's over. So the long view, I think, is one of the characteristics. I guess another characteristic I think is I think a high skill level in dealing with maybe in psychodynamic terms what would be referred to as countertransference. The expectation that that's going to be part of the meat and bones and bread and butter of the work, not just an embarrassing sort of affliction that the therapist might be going through or that the psychiatrist might have, but that it's part and parcel of the recovery process and it's expected, and there's a structure and there's tools for working with it more so than in other team settings that I've been part of.
Well, we are using these substances not in the Windhorse system. It is outside, because also in Germany it's we have a different approach. We have a different situation. We are only working in social care and not so much in therapy. We have to work with doctors, with other therapists together, but they are not part of Windhorse actually. So it is different. So unfortunately, we don't have this possibility to accompany really, or to give this to our patients.
I don't have as much experience with Windhorse teams, but one thing I would comment on from the experience I do have is it's so cohesive, and it's every aspect of life because I think that's something we come up against so much as clinicians, is people not having enough support, or, maybe even people on the team that are working at cross purposes, so to really have that level of communication, and also if someone needs support at home, they have support at home, that kind of thing is so powerful.
Yeah, that's an interesting question. I feel that the work of the psychiatrist part isn't very interesting, except in crisis, but it's very interesting as an OT therapist, because you can see the whole scene unfold, and it's an holistic approach. You can see with the Windhorse methodology, like the body level, the energy level, and the mind level. You can see how this mind operation work in this situation, and what kind of dynamic is going on. And you can watch it, you can comment it, and you can comment it in the reflective situation. And there's a lot of usage of that. But the psychiatric part of changing medication or lowering, going down, is not so much the interesting part.
Hi, I'm Alicia Mandel, and I just wanted to share my experience with Windhorse and being on a team. I've had experience with being in a residential treatment program, and I came here 4 years ago, and Windhorse is amazing. I wish that I had found them earlier, and they have changed my life for the better, and I can't wait to continue my journey with Windhorse. Thank you.
Do you want to say maybe something specific about how you experience the people you work with at Windhorse versus in?
So I started with a team full of probably 6 people on my team, maybe more than that, basic attenders and 2 team leaders and a therapist. And now I am down to 2 team leaders and a basic attender. The support with the team is amazing. I can contact them at any point in time within reason, but yeah. There are days where I struggle with either my anxiety or my depression or other things like that, or I have a question because I've never been on my own. And so this was my first independent situation with a team, and residential programs are really difficult. I was in one for 2 years. So this is like freedom to me, a big, fresh breath of air where I am currently working. And, I see my basic attenders on certain days and certain shifts. And, yeah, it's just amazing. I never thought I would be here 4 years ago at all, ever.
Hi, my name is Stacy. I just have a question about some of the newer treatments with ketamine, MMDI, CBD. With it kind of being like the latest, greatest, that kind of stuff, as far as psychiatry and medications, do you have concerns about what we don't know about it? And what are those concerns, and how do you balance that with how much you do know it helps?
Thank you. Yeah, I mean, well, part of the problem is that we haven't been able to research psychedelics for decades now because they were put on Schedule 1, even though they're not Schedule 1, because Schedule 1 means there's no therapeutic benefit or there's a high probability for addiction, which we've shown that things like psilocybin don't have. And so, yeah, we just need a lot more research. And luckily, I just heard that there's this Imperial College in London just opened a clinic that's solely dedicated to studying psychedelics. And so they're also planning to have a clinic there as well as a research side of things. And so hopefully, more will come out of that. But there's just so many subtleties that, we have anecdotal evidence that some of these psychedelics are helping people with that have had psychotic issues in the past, and then for other people it's exacerbating the issues and making them much worse. And so they just need to be studied more.
There's a lot of research going on now, and I think we're going to get a lot more information over time with that. But even with a lot of medications we don't know enough about the harm they cause. I mean, just even talking about SSRIs. So, in terms of changes to the brain or whatever, long-term use. I think it's the really big important thing for me is that people really need to be screened for appropriateness. Just because they've heard this is so good, it's a danger as a clinician to think it's a panacea or, one size fits all in any way. So, one of the things that we do have in terms of looking at what can be potentially harmful is we do have a certain amount of data historically that's come out of, abuse, street use. For instance, with ketamine, in terms of it causing addiction or it causing damage to parts of the body or whatever, we know with regular street use of ketamine that people develop kidney and bladder problems with that. But it hasn't been seen with the treatment-resistant depression IV infusion centers or using it, in the therapeutic form. It hasn't been seen really at all, to my knowledge. Have you heard different? Yeah. And similarly, I mean, in some ways it's sort of ironic for this country that MDMA is going to have legalization first, because probably of all of these medicines, it has the most interactions with other things and potential risks, with the amphetamine effect, and it can be depleting of serotonin, and it's an amazing tool. So it's just using things really carefully.
Yeah, I think on the illegal market we have a lot of experience with the side effects of these substances. We know, not scientifically, but historically, we know a lot how dangerous one substance is. For example, LSD, there is no death. There is cannabis, there are no death, and so. The side effects and the harm from the accepted medication, from the neuroleptics and antidepressants, is a lot higher than these substances actually are. Because ketamine also is used since decades, and from all the new substances we know a lot less.
And also ketamine actually historically, has been used as an anesthesia drug, so at much higher doses. So we have that, and I just forgot. There's something you said that I really wanted to go off of. I will. If I remember, I'll come back.
I would agree that we're very early on in understanding not only the benefits and the applicability of some of the agents we've talked about today, but also the risks. My brother's an emergency pediatrician. He's used ketamine for 25 years to sew up cuts in the emergency room and set bones and things like that. But those are one-offs. That's one exposure to ketamine, and the patient may not have another exposure for forever, possibly. Whereas I'm sending patients home with it who are getting a good response but don't feel well when they try to stop the medication. So in some of these chronic depressive disorders, looking at potentially decades of use, I certainly caution the people that I work with that we don't know what the future will show us. The risk of bladder toxicity with ketamine and prolonged use, I think, is an important one, and it's one I discuss with all of my patients. With other psychedelics, I can give a case as sort of an anecdote in how different these agents are. A young man who I work with bipolar disorder type 1, predominantly depressed and very seriously depressed, has benefited from use of ketamine, tolerates it pretty well. It's never triggered mania for him. But he has on a couple of occasions decided that he needed more and, quote, microdosed himself with psilocybin and resulted in 2 hospitalizations for mania almost immediately. So the agents are quite different from each other. Well, just that.
I remembered what I was going to say, which is, with traditional psychiatric medication, people are doing daily doses, so you're having a much higher exposure to the medication. And if you're using ketamine for home sessions for treatment-resistant depression, it's usually 3 times a week. I'm experimenting with the client who I talked about earlier. She's going down to doing it 1 time a week because our curiosity is like, how can how much exposure to the medication do you need to maintain an effect? And then theoretically and hopefully with doing it in the context of therapy, then you're talking about using it for a period of time and then for a lot of people and then not having to use it ongoing. So again, it's going to be less exposure to the medication.
One more thing on risks and why we need more research is that we don't even actually know if a bad trip is necessarily a problem, because people can have benefits from these challenging, dark trips. So, yeah.
Yeah, I think in a safe setting, from my experience, in a safe setting, using also music in a special way, like the gong. My experience is that the benefits, they last not only for 1 week or for some days, they last for a month, for several months, or even for a lifetime, just for one session. If you really come to the point where you realize what's going on with yourself.
Just as a contrapoint, in Tromsø in Norway, they have a hospital, a psychiatric hospital, declared as non-medical, no medication giving hospital. And this was the effect of the peer movement there. And in this hospital, I was there, there's an experienced involved client, ex-client, who is in the admission and who breeds the people who come or decides to stay even in the other part of this hospital. But so that's an alternative.
Hello. Hello. Ed Podval put a fair amount of attention into, just as you all have been talking about, having people on the least amount of medications possible, freeing up insight, capacity for discipline, and the faculties of your body, speech, and mind to work as effectively as possible to learn from, ground oneself again, and clarify your mind. Sometimes he spoke rather disparagingly about medications, but he always used them. Not always, but he would use them on almost all the situations I was involved with them. And Chris, you're here in the process of finding discipline and seeing how it's going after having really given this a lot of exploration. And I guess I would just love to hear y'all say something about how what you understand about what people are doing and the conditions for people when they are able to come down to minimal to no medication. What are they able to do, or what's with them that allows that to happen?
For me, a big part has been an internal drive for self-development, for evolving my consciousness and becoming because there are people who are able to be on very low doses or completely off medication. We don't have a lot of data on how many people are able to get completely off of medication because they stop seeing the psychiatrist. So I think what it requires is a complete transformation of the self, and even the culture that you're in. A huge part of my healing was moving to Boulder because it was just culturally very more health conscious and very more progressive or radical or whatever than the city that I was living in.
Maybe in Vienna, one colleague of me, together with me, we do the peer group, and this is very often theme there, how they manage the situation, going down a little bit. Sometimes they get a small crisis, but this is all in this connection of the others who say, don't leave the medication. So this is a part of a conversation, and it is part of a setting, and there it is easier. Sometimes you have challenge problems within the group, but this is a way how you can go down.
One factor I see on this topic is related to this identification that a lot of people will have with being mentally ill, and they've been told that over and over and over again for so long, and they don't see any way out of that. And just kind of opening up that box, I actually think creates a lot of potential for healing. I have a client I've worked with for, I don't know, maybe 6 or 8 years who, started on psych meds at 6 years old. And, he was pretty chemically restrained, frankly, for a really long time. And then he was morbidly obese from the medications. And I've just kind of tracking his progress and letting him direct it and encouraging health has been really profound for him. And he's now only on very rare stimulant use. And I think he occasionally takes propranolol. And otherwise, he's also on daily essential nutrients. And, now his identification is as an empath, which is definitely progress. So
I think essential is finding meaning in life. This is the main aspect, and less fear of dying, not feeling alone, being accepted also by yourself. This is the main thing which helps to prevent, again, becoming ill.
I'll put in a plug for sleep. One of the best ways to dysregulate one's mind is to not sleep.
Well, we have about 5 minutes, and so I'm wondering what everyone wants to do in this 5 minutes. I can't tell you how much I appreciate and have enjoyed this whole situation with everyone here, and with all of the questions and all of the intelligence. This is quite an incredible gathering. I'm so glad it's being recorded, but even more so, I'm so happy that everybody has been here live. So I'm wondering, maybe we could just, in the last 5 minutes, if you just say something in closing. And for my part, I can't thank you all enough for coming so far and for coming so close. And sharing your intelligence with each other and letting us listen to you and then also engage you. And then also everyone here, I know for me this time of day, speaking of sleep, this is a groggy time of day for me, but it has felt so alive. I can kind of feel people being somewhat riveted for this, and it's a very important part of our work, actually. So, Earl, I'll start with you again, since you're here, if you want to say some closing remarks.
Just appreciation for the opportunity to be with you all, and panel members for your illumination of these topics, and wonderful questions from the audience. Thank you.
I'm really glad that all societies all over the world are realizing now what is important, and that what we are trying to create is just the beginning.
I think I just want to say one more acknowledgement about the aspect of relational medicine and the client, which could be the whole family system, taking all that into context as the real expert about themselves, and us meeting them, with whatever level of expertise we have. But I think that partnership is really powerful.
I want to just stress the importance of believing in people, because like Sarah believed, in me that this could work, and that creates a field in the relationship with the psychiatrist that itself is therapeutic. And the power of unconditional love, it can change everything. So thank you, everybody.
Yes, thank you. It was an interesting new knowledge about ketamine, which we don't use only in the university clinic. And the expert role is an important thing. Who is the expert about one's life? And we have a saying, some clients don't have an insight into the disorder. But my question is, how much insight do the helpers have, if they have only half an hour or 20 minutes and on 5 weeks again? So this is on both sides a point.
Well, maybe we could end. So maybe we could end, again, thanking everyone, and I really hope this is just the beginning of much more dialogue. I'm glad that all of you have each other's email addresses, and I hope that you continue to dialogue wherever you are, whatever continent. So we can end with a bow, and then it's time for the next, and it is 4:14.